Okay, perfect.
We're on to part 4 now of our calcium and endocrine bone teaching sessions. We've done one on renal bone disease, the first one, then we did one on DEXA scanning and assessing the osteoporotic patient. So today we're going to talk about how to decide if a patient needs treatment. So this is quite a important topic because there's a movement away in the community from just looking at a T-score of -2.5 and saying you've got osteoporosis, you need treatment, and a movement away from that and towards a interpretation of what is your fracture risk. We should be treating people who have high fracture risk, not people necessarily who have a low T-score. Obviously, they go hand in hand to a degree, but there are a lot of people out there who have a high fracture risk who may not have a T-score of -2.5 or below. So some people have suggested that the term osteoporosis should now refer to people with a high fracture risk and not to people with a T-score of less than -2.5 or below. Okay, so the best way to decide if a patient needs treatment is using fracture risk. So the NOGG 2017 guidelines in the UK are what we tend to use, and there's a section 4 in there which details fracture risk assessment. So the way to do this is using FRAX. Hopefully most of you have heard of FRAX, and you just Google FRAX and you'll get to the website, and I'll take you through it shortly. So FRAX gives you a 10-year probability of a major osteoporotic. So by major osteoporotic, that means clinical spine. By clinical, that means it's come to, there's been a clinical symptom, because a lot of spinal fractures can be silent. So up to half of them can be silent. So they're not a clinical spine fracture, but they're equally as risk inducing. So major osteoporotic, clinical spine, hip, forearm, and humerus fractures. So your risk of having a fracture of any of those sites in the next 10 years, and also gives you a 10-year probability of a hip fracture. So you may notice here that this does not include the tibia, the pelvis, the ribs, other femoral sites, or other bones in the body. And the reason is this is due to the way that the database was constructed and the information that was used. So basically, you can calculate these probabilities, and it's based on studying populations in, I think there are about 67 countries now that have data available, and you can calculate the risk of fracture based on this data in these 67 countries. So they didn't always collect all these fractures, so that's why they're not always included. But if you wanted to include the tibia, pelvis, rib, and other femoral, other bones, you could probably multiply your risk that you come out with in the 10-year probability by about 10%. So if you've got a 10% risk of major osteoporotic fracture, it's probably 11% if you want to include the tibia, pelvis, rib, and other femoral or other bones. So this tool has been validated in lots of independent cohorts, and traditionally assumes the patient has not had any treatment. So there's no point using it in patients who come to clinic who are already on alendronate. It's not designed for that. You can use it because you can estimate, you can get an idea of their risk, but it hasn't been designed for that. So it's not giving you a true risk for patients who are on treatment. It's giving you just a risk for patients who have not had treatment. So the downsides of using FRAX, it's limited to the ages of 40 to 90. It ignores the number and the type of fractures. Obviously, if you have more fractures, you're probably more at risk of further fractures. If you have a vertebral fracture, it carries probably about 2 times the risk of any other site fracture for future fracture risk. So there's no way to input that into this calculator. It ignores your falls risk, so that can be very important in the elderly population. Ignores the dose effects of certain risk factors like the amount that you drink, the amount that you smoke, the exact amount of steroids that you take. It does include steroids to a degree, the doses, but not fully. And it ignores other important secondary causes such as HIV, diabetes, renal disease, and endocrine diseases. So there are two other tools you can use. There's the Q fracture and the Garvan tool, which have slightly different age cutoffs. So the Q fracture is probably a bit better for the elderly patients. You can go up to 99, and you can add in falls, and the same with the Garvan. So maybe these two on the right are a bit more applicable to patients with falls. In the Q fracture, there's a long list of other secondary causes. You can also put in if they live in a nursing home or a care home. So there are lots of different things. But traditionally, and my advice would be to use the FRAX score. It's the most validated, and it's used internationally to decide on treatment initiation.
When you do tadka, right? You do tadka.
Okay.
I put aloo as well.
I think someone.
I put date. Yeah.
I can hear someone.
It's not
done. Okay.
Mute them. Sorry about that.
Yeah, can you mute your microphone if you are not talking? Thank you. Okay, so let's talk a bit more about the epidemiology of FRAX. So here's a graph. Let's start with just focus on the red. Okay, so this is fracture rate on the y-axis with worsening bone mineral density T-scores on the x-axis. So unsurprisingly, as your T-score gets worse, your fracture rate goes up. That's the red bars increasing. Okay, but the important thing to note here, that the actual number of fractures that we see and that actually occur in reality is peaks in the osteopenic range because there are more people in this range to start with. Okay, that's why it's very important not to ignore osteopenia. Okay, don't just focus on osteoporosis because most fractures occur in osteopenic patients due to the sheer number of these patients. Okay, other things that you put into FRAX are the country of origin. So what I do is I basically say if someone's been in the UK for 20 years, then I use a UK population. If they've been less than 20 years, I will use their country of origin population, because you can set that when you go into FRAX. And you can see different countries here have different 10-year fracture risk probabilities. Okay, sometimes you may wonder whether it's just the sort of methodological differences. I'm not sure how Turkey can have such a different one to a Swedish database, but there we are, that's the data that is available. Age and gender, obviously also important. So this is 10-year hip fracture probability on the y-axis as you get older. So unsurprising, as you get older, your fracture risk goes up. And then probably as you become a bit less mobile, then the fracture risk, the probability may actually start to go down once you're over the age of 90 or so. Okay, and then you can see here, obviously, women have a greater fracture risk than men, which is due to the menopause, the massive change in their bone health that occurs around the age of from 50 onwards, basically. Then BMI. So this is interesting here. So just so this is relative risk for fracture. Okay, when you compare a 20-year-olds to 25, a BMI of 20 to a BMI of 25. Okay, so just look at the reds. So that's without any bone mineral density information. So that's without your FRAX. You can see that there is an increase. So this is positive. It's above 1 risk of osteoporotic fractures for those with a BMI of 20 compared to 25. So I'm one of the few doctors that will actually encourage patients to gain weight because it will actually reduce their fracture risk. This is partly dependent also on their bone mineral density. They have more weight going through their bones, and that stimulates more bone mineral density formation. And ultimately, that can be the driver for this favoring a BMI of 25 to a BMI of 20 in terms of fracture risk. Obviously, if BMI is lower than 20, you have other issues. Hypothalamic amenorrhea starts to come into play. So obviously that will then put up your risk again. And then we have other risk factors. So here you can see here that this is with or without your T-scores essentially, and you can see how much other risk factors can contribute to your fracture risk. So putting this all together, you can appreciate how important it is to look at risk factors, because they can make a massive difference. You know, we're talking up to 3 times changes in risk of fracture just because of a risk factor. So we shouldn't just be focusing on the T-score. Let's start thinking about more the risk of fracture. So the next thing to say is that if you add, so this is men and women, they're with different T-scores and the fracture probabilities. And you can see, so in yellow is no risk factors. And then if you add a risk factor, it goes up the risks across the T-scores. Then it adds further. If you add glucocorticoids, if you add family history, it's a massive jump, because family genetics are very important for bone health. But you can appreciate from this that the risk factors are additive and can make a massive difference to their risk of fracture. So let's quickly go through a typical FRAX assessment. So when you Google FRAX, you'll come up with something like this. You can change the country of origin here, and you can enter the age, the sex, the weight, height, previous fracture. So this is fragility fracture, so fall from standing height or less. Parent fractured hip, so always in your histories ask about parental history of hip fracture. Doesn't matter if they were 95 or if they were 55, you still tick it as yes if they fractured their hip. Current smoking, glucocorticoids, you will, they normally say about 5 milligrams or more currently is the, if it's 5 or more for 3 months, then you tick yes. And I'll go into steroids and bone in a future session. Rheumatoid arthritis, secondary osteoporosis, you only need to really tick this if you haven't got the bone mineral density. It doesn't make any difference. If you do have the bone mineral density, you don't have to bother changing this. It doesn't make any difference. And alcohol, 3 or more units per day. And then you put in here the femoral neck bone mineral density. So important here is femoral neck, okay, not total mean hip, which at Imperial is the standard one put in the Cerner reports. You should put the femoral neck bone mineral density. And you should ideally put the raw number, the raw bone mineral density number, because if you put a T-score, it's assuming that you have calculated that T-score based on the National Health and Nutrition Examination Survey data, which is in 20 to 29-year-old women of Caucasian origin. And a lot of scanners like us at Imperial, we don't tend to use that as our baseline comparison data. So you should put the raw bone mineral density in here. Okay, so here's an example of a patient with osteoporosis, 72 years old, and here's the weight and the height. No additional risk factors, but just a T-score of -3.1. Okay, so major osteoporotic risks, that's the risk of fracture of the spine, the hips, the humerus, 20%. Hip fracture, 7.6%. And then if you click on this, it says View NOGG Guidance, you'll come to this screen. And here you've got the various ages and the risk of fracture, and X marks this patient, okay? So she's 72, as we said, she has a 20% risk. She's on the border here of requiring treatment, that's the red. As in treatment, that means like bisphosphonates or denosumab or zoledronate or teriparatide. All patients should be on calcium, vitamin D in theory, okay? And green means just lifestyle advice and reassure. Then you look at the hip fracture side, and this patient is above the treatment line, so you would err on the side of treating this patient. Now, in different countries, these thresholds, so that is where the red and the green separate, varies. Okay, so in America, they will treat anyone, no matter what the age is, above 20%, and above 3%, so all the way across here on the hip. So 20 and 3 is what they tend to do in the States. Here we take into account a bit more the age, and we use 20 and about 5 for the elderly here. So here's an osteopenic patient. So this is really where this FRAX comes into its own. So don't ignore the osteopenic patients. So 72 years old, no risk fractures, no risk factors, height and weight the same as the previous patient, a T-score of -2.1. So 12 and 2.9% are the results. And that places this patient in the green. So you'll say lifestyle advice and reassure, and maybe reassess in 3 to 5 years. Now, if we have the same patient, but now say that she has had a previous fragility fracture, so that box is ticked here, and we say that she has a parental hip fracture, and we tick that box here, this has a dramatic change on the risk scores here, 29 and 12%, okay? So if we take us to here, now we're well in the red, even higher than that osteoporotic example I gave you earlier. So this demonstrates the importance of not ignoring the osteopenic patient, especially when they have multiple additional risk factors for fracture. Okay, so the message today is use a fracture risk algorithm to decide on the treatment, especially in your osteopenic patients. These are where all the fractures tend to happen. FRAX is a very simple thing to use. It takes about a minute and is evidence-based to back up your decisions. And it's very good for convincing patients that treatment is needed, because you can say, here is your risk, it's 25% of a major osteoporotic. I can now give you alendronate, and that will reduce this risk by up to 45%. So from the 25%, it will go to about half of that if you start them on a bisphosphonate. And this can be quite powerful. The reason we use 10-year risk of fracture is that it is a bigger number and easier to convince patients, essentially, when you give them the 10-year risk, but rather than if you give them a one-year risk, which will be about be divided by 10 of the 10-year risk. So the threshold for treatments vary by country. So as I said, in America, they have slightly different thresholds, but I think this sort of demonstrates the interesting side of the deciding each case in an individual basis when assessing the need for treatment in low bone mineral density. Okay, good. So we've done those three so far, and I think next time we'll be doing steroids and bone. Okay, so thank you very much. And I think you need to scan this QR code, I believe.
Yes, thank you. Thank you very much. I'll leave that QR code up there for a minute. Oh, it's gone. Let me put mine up. So there's a couple of things I've had before I start. I've had a few emails about certificates. So certification will follow in about a month. If you use the QR code and then feedback, you need to wait for a few weeks before I'll put them all together, because people are doing it about a week late sometimes, which is allowable. This is from the RCP that says you don't need a certificate. If you're an RCP member, you just need to search in your library by date, and you will find it. So these have been approved, the last two. The next one's being approved shortly, but these are the codes. You don't need the code. You just need to look in the RCP webpage, and you should be able to find it. Okay, so let me just go back to minting. Okay. There was a question from somebody, if you want to look at that.
Yep. So from David Riley, do you have a recommended way of assessing and managing fracture risk for the young patients with relatively good T-scores, less than -1, but with rapid bone loss, assuming the cause can't be treated, i.e. due to medications? So that's a very good point. Thank you, David. So just to remind ourselves, basically we try not to use T-scores in patients under the age of 50. We should use Z-scores. But let's say it's -1 and there's rapid bone loss. You're basically highlighting this issue that sometimes another decision factor, an important decision factor, is the rapidity of bone loss. When you look at the DEXA scan results, have a look. Remember, I showed you where to look for change from previous. And if you can see a very rapid bone loss, even though at that point they may not merit treatment, you may think, actually, I'm going to start treatment because it's rapidly going down. The exact way you're going to manage it depends on, can you change them to steroid sparing agents? I've just been involved in drawing up some COVID related bone protection guidelines for here at Imperial, because we have over 50 patients who are on extremely high dose steroids for their lung disease post-COVID. And obviously, ideally you stop you can need to stop the steroids and switch to something else. Ovarian suppression in breast cancer is another. So we've got a lot of patients who are on letrozole and things like that. So it is a case-by-case scenario. There's no necessarily right answer. There are a lot of factors to take into account, but you can use bisphosphonates in young patients where appropriate, or denosumab or teriparatide in some cases. So it all depends on the mix of the patient. So prophylactic bone protection in patients with primary hyperparathyroidism. So in primary hyperparathyroidism, ultimately you want to remove the offending parathyroid adenoma or adenomas to relieve the pressure on the bones. But you can, stabilize things with, there's a good paper recently in Italy where they gave denosumab and showed that you can, you can preserve the bone, if not make it a bit better, whilst they still have ongoing primary hyperpara. However, the danger here is if you're going to proceed to surgery, you will get hungry bone syndrome. Essentially, if you've got already loaded them with anti-resorptive treatment. And that is because once you remove the PTH drive to get the calcium out of the bones to maintain your circulating calcium reservoir, once you lose that high PTH, suddenly you can't get the calcium out of your bones. And so if you haven't got an adequate calcium intake, you will drop your calcium, you'll get hypocalcemia, post-operatively, which can be very tricky to manage and probably require activated vitamin D and things like that. Next one, 17 years old with Z-score of -3.5 with hypocalciuric hypercalcemia. Will you treat with bisphosphonate? So this is the patient with FHH, I guess, who's got a Z-score of -3.5, 17 years old. So I don't like, I'm very reticent to interpret Z-scores in very young patients where they're still to gain bone. So she hasn't reached her peak bone mass, which will be more than a decade later. So what I might do, if she hasn't already had a fracture, is I will, she may just be behind the curve in terms of getting to her peak bone mass because of some illness or investigations and things like that. I will, in these patients, tend to optimize their calcium and vitamin D, encourage exercise, enhance other lifestyle factors, and maybe repeat DEXA in 18 months just to check that things are improving and not deteriorating, because that will be the real marker if things are going wrong.
Okay, I think I'm going to